I'm happy to be here, and thank you to the organizers of the conference for giving me a chance to tell you something about something that we see once in a while, maybe sometimes every day, unfortunately, for our patients. And I hope that at the end of this talk, we'll be able to see where we've been going wrong, see what we've been doing right, and help our patients further. So I have no particular financial or otherwise disclosures for this particular talk. And we shall start off with cases, as we always do, because we always see this. So I hope that these will come to your mind as we discuss. Let's start off with a 28-year-old man with HIV and on ARVs. He's of course on hemodialysis using a tunneled catheter, which are commonly called permanent catheters, wrongly called so, of course. He presents to you at the emergency department with a fever, rigors, tachycardia. And of course, when you examine and do some tests, maybe you find a leukocytosis of sorts. At this point, what are you thinking and what are you going to do? This is a very common thing that we see in our centers. And of course, it's something that we should be able. Nowadays, like Professor said yesterday, this could be COVID. But also this could be catheter-related bloodstream infection. I'll be calling it CRABC so that we can speak a bit faster. A second common, maybe not so common case is we had this actually last year. Dr. Moturi sent us this patient. A 57-year-old woman with hypertension and diabetes. She was on a transplant workup, hemodialysis via tunneled catheter again. She had multiple failed vascular accesses, and we hospitalized her because of fever and a 1 week of progressive severe back pain. So this is about the complications of catheter-related bloodstream infection. It doesn't normally stop in the blood. It could go somewhere else, and you have to keep this in your mind, as we shall see later on. Right, so the definition is actually quite simple. And it requires clinical signs of infection. So whether if someone is having rigors or having fevers or having a headache, or having altered mental status, some of these people just come when they're looking just sick and you wonder what's going on with them. They just look sick and they're not even febrile. They just look not fine. Someone, once in a while, a nurse calls and says, "Doctor, this one is not looking fine. He doesn't look as he looked last week on his previous session." Then some of them have unexplained hypotension. So when you have clinical signs of infection, you have ruled out the presence of an alternative source of a bloodstream infection, whether it's going to be malaria or a UTI or something else that can cause, these kind of signs. And then, of course, for those who can, preferably, you should have a blood culture. And these blood cultures, preferably from a peripheral vein, and one of the following, whether it is a catheter segment, when you take it out, and you've seen us sometimes asking for a catheter tip culture, or if you do simultaneously, you obtain blood cultures from the catheter. So, this other one is routine blood cultures of growth. Still, you need the blood from the catheter. So you have clinical signs of infection, and then you have a positive blood culture that is both from the blood drawn from the catheter and blood drawn from a peripheral site. If you can do that, then you'll diagnose catheter-related bloodstream infection. Once in a while, of course, this doesn't go so well in the times when you do not have a catheter blood cultures available for you as a doctor or a nurse. So these definitions, there are mainly about 4 or 5 groups that have looked at how to define this. Here we have the CDC, we have the Infectious Disease Society of America, which is normally what we use, the 2009 guidelines. They are quite old, but they're still very, very useful. And of course, the KDOQI guidelines, and then the Public Health Agency of Canada. They pretty much say what we said in the first slide, so I'll not be going through that for you guys. More often than not, most of the bacteria are gram-positive bacteria, about 40 to 80%. So you have Staphylococcus is very, very key because it is usually on the skin. We have some people who carry it in their noses for some reason, A, B, and C. We do not know why. And we have also Enterococcus. We have gram-negative bacteria, which take about maybe 20 to 30% of the patients. Once in a while, it is polymicrobial. So it's combined gram-negative, combined with gram-positives. Some unfortunate patients get fungal-related infections, and that is not nice at all, but it's less common. So the risk factor is where I'm going to take a bit of time, because as you see, this is something that you want to avoid because we know that the problem with catheter-related bloodstream infection, not only do they cause morbidity, these patients get really sick, but they also cause stress for the health worker. They unfortunately increase mortality of these patients. So someone has, if you look at the line of survival of patients who have had catheter-related bloodstream infections and those who have not had them, the survival for the ones who have catheter-related bloodstream infections or CRABC is worse than those who do not have. So it's something you really, really want to avoid. So these are some of the risk factors, and I'll mention mainly maybe the first three, but even the others are very important. Submaximal barrier precautions. I wanted to ask Dr. Sokwala for his picture, but I'm glad that he showed it in the previous slides. So barrier precautions are, they are multi-pronged. It's not just what you wear. It is where the patient has come from, what the patient looks like, what your hospital is able to give you to prevent, to have asepsis. When you normally write in your notes, aseptic technique observed, sometimes you ask yourself, but was I really aseptic? You're asking yourself something about that. So, it goes deep, not just to what you're wearing, but even what the patient looks like. See, mgonjwa ametoka sijui wapi, he has come very fast. You want to put a catheter very fast and also leave very fast. Those issues of very fast can bring you problems. Once in a while, you use the wrong antiseptic, you maybe even don't use, unfortunately, for some of the patients. Mgonjwa amekuja bado hajaoga, etc. Are you really thinking about, asepsis as a technique? Once in a while, professor finds you in the unit putting a catheter without a cap on the head, and he taps your head. And these are some things that you really have to think about, because like we had in the previous talk, this is a lifeline. It's a lifeline of the patient, whether it is non-tunneled, whether it is tunneled, they need this, and it's up to you to put it in properly and safely. So barrier precautions for the patients and for you are very, very key. And this is where one of the risk factors, this is why you put it in red, that is one of the higher, issues that causing these CRABC or related infections from catheters. Now, the longer you use a catheter, the more likely it's going to get catheter-related bloodstream infection, or the more likely you're going to get problems with that catheter. It goes without saying, it has been shown in studies, and we have seen it happening. We had a patient at Aga Khan. This particular patient had his catheter for about 2 years. And then I think someone convinced him to he came to Mombasa for a trip. Remember that guy? Then he got, I think he became very happy. He went swimming and he came back. Just a week after, he came back with an exit site infection. So even when you're talking about, barrier precautions, some of those things even happen after. What I tell in the patients, how I tell in the patients to keep this catheter clean for themselves, because after they've left your unit and they come back twice a week, thrice a week, what is happening in between? How are they bathing? How are they keeping it clean? Something for you to think about. Non-tunnel catheters get more infected than the tunnel catheters, because the tunnel catheters have a cuff I would have loved to show you maybe the anatomy of the catheter. It would have been nice, actually. So they have a cuff that prevents, kind of reduces the infection from, from accessing the vessel and causing an infection. The site of insertion is also key because the femoral area is not very clean, so to say. Internal jugular and subclavian. So subclavians do not get infected more than the internal jugular, but of course we do not like them because of central stenosis. If someone has a previous episode of CRABSI, they will most likely get another episode of CRABSI if you do not do something about it. So that is a risk factor as well. There is something called Staphylococcus nasocarriage, and the previous speaker talked about it. Once in a while, or most of the times when you are connecting a patient, you actually tell the patient to look away. So if you've never known why, the main reason is because there are some patients, or some of us, not even patients, who actually have Staphylococcus aureus within our nasal areas and nasal cavities. And if they are looking at the site where you're putting the, putting the blood lines and putting the what, even on the time when they are putting the catheters, they are looking there, you never know. They might pass on that Staphylococcus aureus to the site and cause an infection after that. Diabetes, hyperlipidemia, and recent surgery are also risk factors for catheter-related bloodstream infection. So around CRABSI, there's also infections from catheters. You've seen some in the previous slide. You can have patients who are asymptomatic from their infection, and until you do an infrared thermometer, that's when you catch them with maybe a hypothermia or a fever, and it's something for you to always consider. If you do not, unless you look for it, you might not find it. You might ask yourself, why is there checking temperature in our standard operating procedures before I connect the patient? Maybe this is why, because some of these patients do appear asymptomatic, and until you look for it, you might not find it. There are people who get exit site infections. You've seen that in the previous slides. It's normally red at the entry of the catheter, and it could be red, it could be swollen, it could be painful. You might have pus coming from there, and that will tell you that this patient has a catheter infection. One of the things you don't like seeing is a tunneled infection. A tunnel infection is, is where you get, an infection that has really affected the tunneled part of the catheter. And it might be an abscess. It might just look as bad as that. Once in a while, it might just be red and maybe painful, just like you saw at the exit site as well. So when it comes to CRABSI, like we said, patients might be asymptomatic. And these are the ones who maybe after connecting on the machine, you see them starting to get rigors. You're wondering why. They might start to get all kinds of symptoms. They are getting, now the temperatures are creeping up, and you're wondering why. Some of these patients do have CRABSI. Sepsis is something that, that's how they can present. Patient presents to you with, hypotension. They might present to you with, in respiratory failure for whatever reason it is. And this is because the infection has really caused an organ dysfunction from that particular infection. Now, another thing that you see with CRABSI once in a while is metastatic infection. What starts as infection of the catheter goes into the bloodstream, might actually metastasize, so to say, to another site. Most of these sites could include the back. Some patients might have spondylitis or discitis. The unfortunate ones might get an abscess in their back or in their epidural abscess. And these ones will present to you with back pain. A patient we had with metastatic infection had septic arthritis. The knee was swollen, it was hot, and it was very tender, and they were limping. So you know, unless you look for it, you might not find it. And that is different from treating someone who does not have a metastatic infection, you see. So if this patient, you remember case 2 had back pain. So there are these patients who are on the machine, they're on dialysis. And for some reason, it keeps telling you, I have this back pain. I don't know what's happening. Then on the machine, he gets a bit shivery. Do not ignore that pain. Do not ignore back pain. Do not ignore knee pain. Do not ignore headaches or even sometimes convulsions, because this might be brain abscesses. Right, so we go into the principles of management. Lucky for me, I don't have too much time. So clinical assessment, I've tried to spend some time on clinical assessment because it determines a lot how you're going to manage the patient, how you're going to stratify them, and how you're going to refer or not and consult is very important. How you assess them at admission, how you assess them on the hemodialysis session before you start means a lot, and you have to keep that in mind. Blood cultures, like we saw earlier on, are advised and should be done ideally, so that you know what you're dealing with and treat accordingly. If you do not have blood cultures, I'll show you what we do in such circumstances. And then, of course, investigation for metastatic infection. If someone is having a backache, is an X-ray enough? Once in a while, the X-ray will not be enough, because when you're looking for an abscess or discitis or spondylitis, the X-ray will not see it. So once in a while, you see us asking for an MRI of the back. You see us asking for a CT scan with a bone window, so that we can see if this patient has an abscess there. If someone has a knee swelling, once in a while, you do not really need to examine a knee swelling with an ultrasound scan. But if you can, well, go ahead and do it. This particular one we did not have to do it because the patient had a very swollen knee. She was limping, and using techniques we were able to aspirate, and it was actually a pass in the knee. Empiric antibiotics are very important, because before you get your blood cultures within 48, 72 hours, you have to start something. And remembering what we said in the 1, 2, 3, third slide, most of the organisms are gram positives, but 30% could be gram negative, and then 10% could be polymicrobial. So most of the time we do a mixture. We cover both gram negatives and gram positives. And one of the drugs we love to use is vancomycin, ceftazidime for the gram negatives, and also for Pseudomonas for those who might have gotten it as hospital acquired. And I'll show you how we go into that and the duration of therapy. Metastatic infections, the duration is longer than non-metastatic infections. There is the principle of catheter removal. You know, when do you remove the catheter? Should you remove it, or should you salvage it? Salvage means really going conservative about it and not removing it while you treat the patient. If you remember case 2, this patient had multiple catheters, and you're not sure if you remove this particular one, are you going to be able to reload or to reload another one? Are you very sure about that? So you start thinking, maybe I should keep this one in. Maybe I should not take it out. So many things, we consider several things as we consider catheter salvage or removal. One of the other things we consider is if it is temporary. If it's a temporary catheter, and it's infected and has caused CRABSI, it should come out. It should come out. But then you also start thinking, I remember when he was buying this catheter, he had to sell his goat fast. So now how many goats does he have? Will he sell another goat? Will he talk to his neighbor? Will he have to marry off the daughter first to get another catheter? There are many things surrounding catheter salvage that you have to think about, and not just you and the books. And of course, you have other supportive and definitive treatment as per presentation. You've heard about consultation to the orthopedics. You've heard about, analgesia. You've heard about antipyretics. You've heard about, removing pus from the knees. If that is needed, then please go ahead and do it. So this is the busy slide. There are some small things, but I'll just go through. If you have a suspected catheter-related blood infection, like we talked about, obtain blood cultures if you can, and start antibiotics. Yeah. If it's uncomplicated, the patient is hemodynamically stable, is not, is doing well, is just having rigors on the machine. You think about and is responding quickly to empiric antibiotics. You just go ahead and do 2 to 3 weeks of those systemic antibiotics, and then maybe you can do 4 weeks of 2 or 3 weeks, or even 4 if you want to. There's something called an antibiotic lock. I'll dive into that in the next slide, and I'll remind you about that. If it's complicated, someone is unstable, is septic, is having that, then you might want to go about 6 to 8 weeks of antibiotics, but we shall go into this a bit later as well. Catheter management, you can keep the catheter if there's rapid improvement on antibiotics. They're hemodynamically getting stable within 24, 48 hours. You can keep the catheter. They advise you to remove it if the person is severely septic, so that you can so what you call source control. Because if you're having CRABC, the source is the catheter. So source control can be very key in that particular patient. And if someone is hemodynamically unstable, if you have evidence of a tunnel infection, you remember the infection I showed you on the tunnel, then you're advised to remove that catheter. If someone has persistent fever despite antibiotics, 72 hours, the fevers are still going on, patient is not getting better. Even if you had decided to leave the catheter in, you might lose this patient. So the catheter, you might have to take it out. And then there are some pathogens. If you have grown Staphylococcus aureus, if you have grown fungus, if you've grown such multi-drug resistant organisms, then that catheter should come out. Otherwise, you're not doing the patient any good. Right, so systemic antibiotics, like I said, we normally use vancomycin, 20 milligrams per kg, loading dose, and ceftazidime, 1 gram immediately after hemodialysis. The other options, you could use daptomycin, gentamicin, but usually we try to avoid those, depending on how sick and how much residual renal function the patient has. Cefazolin can be used for some of the patients if you have blood cultures that are positive for that and are sensitive for that. Now, catheter locking with antibiotics. How many of us have used catheter lock with antibiotics? Show of hands. Good. Yeah, 5%. Right. So it's not. I've not seen it being done, and I think it depends on institution. But usually, if you are trying a catheter salvage or you're trying to do conservative care for the catheter, then studies have shown that a catheter lock might be a good adjunct therapy. So you're advised, you could use vancomycin, ceftazidime, heparin, and there's a way you can mix it. It's on this slide. If you put vancomycin 1 ml or 5 milligrams per milliliter in normal saline solution plus ceftazidime, this is still empiric. 0.5 mils of 10 milligrams per ml in normal saline. And then, of course, you have to use the heparin because you normally lock with heparin anyway. So when you lock like that, you might save the catheter, you might save the patient. We do not have any local studies, so I'll not comment on what we do in Kenya particularly. Right. So removal of catheters, I've talked about this. I have not cultured mycobacteria on catheters yet, but I can imagine if you have it, then this catheter should really come out. So that's something for you to consider on that side. Good. I'll talk about it. So this is the antibiotic lock for treatment that I talked about. So it's indicated for patients with CRABC involving long-term catheters with no signs of exit or tunnel, for whom catheter salvage is the goal. If you're removing the catheter, then you do not have to do an antibiotic lock. And I would like to know from my seniors what they think about antibiotic lock therapy at the end. Normally do it at the end of each session. Success rate is about that, and the about 87 to 100% if you have gram-positive pathogens. It gets lower if you have Staphylococcus aureus. It's a bad animal. And those antibiotics I talked about, you mix the antibiotics and heparin as well. So in peripheral settings, when you do not have, when you're resource limited, like how most of us are, there are some unique features about CRABSI that always cross our minds. So one of them is these patients are usually outpatients. They come and they're getting shivers on the machine and you're wondering what's going on. So something for us to remember. The ability to provide parenteral antibiotics during hemodialysis sessions, you might not have parenteral antibiotics, depending on where you are. If you do have, that's a good thing. And then, of course, there are some dialysis units that are at geographically remote sites and not adjacent to a hospital. And then, of course, sometimes you do not have a doctor near you. What are you going to do? What are you going to do? So empiric antibiotics should always be at the back of your mind so you can be able to help. And then also to remember the clinical features we talked about. Right, and then this antibiotic drug levels are not routinely done, not even in the beta centers. It's something that maybe you can not think about. Right. So can it be prevented? The good thing we've talked about this in the previous discussion. I'll not dive into it. We've talked about the dressing type. We've talked about the antimicrobials, and we've talked about the topical antimicrobial application. You see nurses applying mupirocin on the site, and some of this is what saves these patients. If the patient has nasal carriage of Staphylococcus aureus, we have data that if you use mupirocin, that could save the patient from getting CRABSI to some percentage. And then, of course, the antibiotic locks that we talked about. So the first case, I told you, you should go 3 weeks dialysis ceftazidime. Right, and then go to sort of ceftazidime catheter lock. Surveillance cultures were negative and the catheter was salvaged. For the second one, however, they had to do a thoracolumbar CT spine, and that's what they showed, spondylodiscitis. Of course, now when you find spondylodiscitis, then you have to look around for any other metastatic infection, echo to look for infective endocarditis, etc., etc. Fever resolved after treatment for about 6 weeks, and she did fairly well. At some time, I think she came back and she had an abscess, which had to be drained now by the orthopedic officers, orthopedic surgeons, and the like. The CVC was maintained, unfortunately, because of the issues of the CVC around there, access issues. Right, so I don't know what you would have done differently for these cases. And I would like to know what your experience is with the dose of ceftazidime and vancomycin in your institutions. Some give 1 gram, some give 500 milligrams after dialysis. Ceftazidime sometimes given every 72 hours, others give it after hemodialysis. So if the patient is on hemodialysis 3 times, do you give it 3 times a week? Something for us to think about. And then do we do vancomycin levels? It would be nice to know what the vancomycin levels are in our patients who we are treating. And that is something maybe a registrar can take up as a study. I thank you very much for your attention. And yeah.